Good afternoon. We're going to call this meeting to order. Appreciate everyone's patience while we develop our quorum here. If we could, let's have the...
Senator Alvarado, Senator Carroll, Senator
Present remotely from my district.
Thank you. Senator Higdon, Senator McGarvey.
Present remotely from my district.
Thank you. Representative Gooch.
Here in my annex office.
Thank you. Representative Gibbons-Prunty. Present in the room. Thank you. Representative Sheldon.
Present in the room.
Thank you. Representative Wilner.
Here in the 35th House District.
Thank you. Senator Meredith.
Present in the room.
Representative Elliott.
I'm present.
Wonderful. Thank you.
Thank you. Yes, we do have a quorum. First order of business on your agenda, but let's have the approval of the minutes. Is there a motion?
Motion.
Is there a second? Motion and a second. All those in favor say aye.
Aye.
Any opposition? Passed unanimously. Thank you. We've got three great topics this morning, or this afternoon, excuse me. This is the third committee meeting, and they kind of run together after a while for somebody my age. But first, we're going to go suspension of prior authorization for behavioral health services. And I see Miss Dr. Schuster is here. If you'll come forward along with your guest, if you have any. Mm-hmm. Aren't we lucky? I am on a roll today. Well, you've been here many, many times, Dr. Schuster, and we always appreciate your testimony. But if you would, please identify yourself for the record and please proceed.
Okay. That's
You're
good.
good.
Thank you. Dr. Sheila Schuster, I'm a licensed psychologist and executive director of the Kentucky Mental Health Coalition. And I appreciate very much the invitation from the committee co-chair, Senator Meredith, and the members to talk to you about a favorite topic of mine, the suspension of prior authorization for behavioral health services. So I'm going to go very quickly through these first slides because they really are kind of background, and I think most of you all are quite familiar, but prior authorization is what they call utilization management used by the insurers to make sure that everything is safe and cost savings. The providers see them as being costly, time-consuming, and more importantly, delaying or denying care. You may remember that in the 2018 General Assembly, we had House Bill 69 from Representative Ken Fleming that tried to do a single credentialing, but also talked about a single medical necessity criteria, which would be so helpful because we have 6 MCOs. They all use different medical necessity criteria. They use different ones for physical health and for behavioral health, and sometimes even different for substance use disorders. But unfortunately, they've not been able to come up with a single medical necessity criteria. So our providers have to kind of remember which MCO they're dealing with and what those particular PA requirements are. There is a fail-safe for the insurers, so if they come crying to you that they're losing a boatload of money because they can't prior auth behavioral health right now, number one, remember that the total spend, I think, for behavioral health and Medicaid is certainly less than 5%, maybe more like 2 or 3%. So we are very small but important when you think about the people we serve, but a very small part of that budget. They do have the right to do what they call retrospective reviews, where they can come back and look at the case records and then come back and recoup payments, which of course the providers live in fear of that happening. So a good thing came with the COVID pandemic, and that was that our Kentucky Department for Medicaid Services suspended all prior authorizations except for pharmacy. And since that time, that took place at the end of February of 2020. Since that time, they have restored the PAs for some physical health services, except those related to COVID. But to date, the PAs for behavioral health, and when we say behavioral health, we're talking mental illness and substance use disorders, those have remained in place. So we get a monthly update or a bi-monthly update on that status of the PAs because they are reviewed monthly, and the DMS would give us a 30-day notice if they're going to be reinstated. Just to remind you that what we're talking about, what we're going to focus on today is really the severe mental illnesses, substance use disorder, and this also affects children with severe emotional disturbance, but where most of my data is around adults with either SMI or with substance use disorders. So almost every service that you can think of requires a prior authorization, from the initial services and establishing a diagnosis and a plan of treatment, and then these other services, which we'll get into a little bit more. The most important of which, at least for our folks with severe mental illness, is targeted case management. We also have day treatment programs that are called therapeutic rehabilitation. We have therapy services. Again, for people with severe mental illness, we have assertive community treatment and community support services. On the SUD side, we have intensive outpatient treatment, IOP. Of course, we have detox, and then we have residential treatment, either short-term or long-term. And every one of those requires this prior authorization process unless it's suspended. So let me just remind you that we're talking about the COVID period. And as you all know, probably from your own personal experiences and from those of your constituents, COVID has been extremely, extremely difficult on the behavioral health of probably every living being. I don't care whether you have a diagnosable condition or not. And some of us feel like we may end up with a diagnosable condition because of the anxiety and the depression that comes with it. So it's kind of what a friend of mine called the trifecta for anxiety. It's an unknown time frame of undetermined consequences and a total loss of control. And that's really bad for us human beings. We don't handle that well, and we react with anxiety, depression. We also abuse substances during that time because we self-medicate those feelings, those uncomfortable feelings. We worry about our kids. We worry about our parents. That sandwich generation, I think, is really feeling it. I have a granddaughter who is 10, so she can't get vaccinated. And, you know, I worry to death about her and her activities, whereas my other grandchildren can all be vaccinated. So this has been a hard time. Imagine if you already have a diagnosable mental illness or substance use disorder, and then COVID hits. And I know that Senator Alvarado would agree with me when we say a lot of people fell out of recovery for substance use disorders. A lot of people went back to using those substances, whether it was alcohol or opioids or illegal substances. The warmth of an AA program or an NA program was not there because you couldn't do it in person, and it's really tough, particularly for people who are new in recovery. So this has been a really, really tough time for behavioral health. In May, Commissioner Lee reported at this committee these increases in spending, and this is kind of the COVID period. So this is the comparison of July to February 19 and 20 to 20 and 21. And you see mental hospitals way up. You see the residential crisis stable units, we call them, a big increase. The psychiatric residential treatment facilities are for youth, the PRTFs. And then you see the CMHCs. And I don't know whether that includes the billings from what we call our BSHOs, the Behavioral Service Organizations, or not. I think that those increases are to be expected, quite frankly, if you think about what's going on during this COVID period. Some of the providers who do in-person therapeutic rehab had to cut back, certainly on those services, could not do them in person, and some of our clients do not do well with telehealth. Other providers reported that they did more outreach to kind of keep track of people and chase them down if they needed to. That's what the assertive community treatment teams do. So we think that prior auth should be assessed on a case-by-case basis. And what we hear from the MCOs are that they have these kind of in their head, because they're not in reg, arbitrary and preset limitations. One MCO said, well, we're not going to authorize targeted case management unless your client is in psychotherapy. Well, if you have an active psychotic disorder, you are not a good candidate, I will tell you as a psychologist, for what we think of as traditional psychotherapy. And so they wouldn't authorize other services, which again doesn't make a whole lot of sense. Another said that, you would only need targeted case management for a 12-month period over a lifetime. And I'm telling you, folks, I think it's akin to saying, okay, you have a diagnosis of diabetes. We're going to limit the amount of insulin that you're going to get over a lifetime. That's how important some of these services are to keeping our people out of the hospital, out of jail, out of homelessness, out of trouble, out of suicide. And to have these preset arbitrary limits is just unconscionable. They don't take into account most of our CMHCs and the BHSOs are accredited by the Committee for the Accreditation of Rehab Facilities, or the Joint Commission, as well as obviously the licensure through the cabinet. So they already have those qualifications. We should not be rationing services. Mental illness, severe mental illness, is not a linear disease, meaning it's not predictable. In fact, the most predictable thing about SMI is that it is unpredictable. And I put in your packet a short but very well-researched article from Dr. Rifa Malik, who is a professor of psychiatry at the University of Louisville. And, you don't have to get into the weeds around the biology of psychosis, but if you will just look at what he explains about how psychosis works and the importance of somebody acting literally as the frontal lobes of people that have a psychotic disorder. It's a great explanation of that, and it talks about how those services really provide, and we can teach people to learn those services, but it takes a long, long time for them to be able to do it. We know that recovery is an up and down. In fact, I've often thought that the hardest diagnosis that you can give a parent is that your child has a severe mental illness or an acquired brain injury, because they're the two that are lifelong without true recovery. You're going to have those illnesses your entire lifetime. And again, the unpredictability, those peaks and valleys. And what we try to do as providers, particularly in your safety net, which are your community mental health centers, we try to keep those valleys from being so low that the person ends up in real trouble. So we're trying to keep in touch with them, to predict changes in their functioning, and to get to them with additional services, or to make sure they're on their medication, or if they need a change in medication, which again, as Dr. Alvarado knows, is not always easy because of the shortage of prescribers in the behavioral health community. So again, these are some of the reasons that were given by the MCOs that we think are not substantiated by the research for sure. On the SUD side, there is strict criteria. Again, the ASAM, the American Society of Addiction Medicine, is used by our CMHCs and our other SUD treatment providers, and they do a great job of assessing the need of the client for the services. So actually, they go through this long process of getting a PA, and then they end up actually not getting denied most of the time. If they do get denied, it's typically an error on the part of the MCO. If they do, it's for something like a time frame. So here comes a client who really needs to be in recovery and finally is acknowledging that they do. What's the first rule? The first rule is to get them the heck into treatment without any delay. The slightest delay causes them to think twice about it, or, get another urge or whatever, and then they're out the door. So getting them into services is the most critical thing. PA is a delay tactic. It takes up time. The MCOs tell us that we can't get people into, for instance, a short-term rehab program, a residential program, in advance. So we have to wait until they're actually admitted and then try to go through the PA process, which very often doesn't get approved until day 2 or day 3. And the providers, of course, take a loss. And, of course, it doesn't make any sense. If they meet criteria on day 2 or 3 for that service, they sure as heck met it on day 1. One of the things that you learn about behavioral health providers, and again, I think Dr. Alvarado has this firsthand, is that we don't turn people away. I mean, even if we know we're not going to get paid, we keep the doors open. The CMHCs have done themselves in financially and in every other way by continuing to see people even if they weren't sure they were going to get paid because people needed the services. So delay is a critical issue. We don't want people to fall through the cracks. We want to be able to keep an eye on them and look for changes, and we want there to be continuity of care. So we have a woman, this is a little case study with SMI, who needs to learn literally what we call the activities of daily living: housekeeping, shopping, preparing a meal. She wants to live on her own for the first time, and we have a program in Louisville that is available through Wellspring, which is a BHSO that does what we call supported housing. It's what we could do if we had a Medicaid waiver for people with SMI. So it gets people into housing with people right there to help them learn those activities and to keep an eye on them. So she also had significant physical health issues, which is, again, the norm for our people. They don't go to doctors. They're not always well accepted in primary care settings or even in the hospital ERs for physical health. So the targeted case management was used for both of those things. And again, the MCO said, well, she shouldn't need it for more than 6 months. Well, this is a woman whose frontal cortex, her executive functioning, is not functioning. And for her to go alone to a doctor's office, she's not going to be able to tell them what it is that she needs or to understand what she's hearing back from the physician. That's what a targeted case manager would do. People with severe mental illness die 25 years younger than their peers without a severe mental illness. So what has been the effect on staff? Guess what? Staff has more time to actually provide services because they're not hassling with the MCOs. They're not on the phone. They're not faxing and refaxing and so forth and waiting. They're also not having to stop in the middle of a treatment progression to say, oh, wait a minute, I got to get a PA in for that next little group of services that I need to get approved and so forth. Service staff has said the release of stress during this period when they haven't had to do prior authorizations has just been remarkable. This gives you an idea. This is from one of our CMHCs. It's roughly an hour per patient per week that is spent on just the hassle and the paperwork of a prior authorization. So you start multiplying that with caseloads of 20, you're really talking about, and people are doing the PAs, in between when they really don't have time to do them. So some of the, obviously the bottom line is we can save lots of administrative time and actually spend it on treating clients. So again, we have the internal mechanisms for doing this. What's success? And this is interesting. One of the MCOs said, we're not going to authorize any more targeted case management because the patient is not showing an improvement. Well, success for many of these patients is stabilization. It's keeping them from going backwards. And I call that improvement, quite frankly. If we know where they are and that they're taking their medication and that they're engaged in some meaningful activities and so forth and are not getting in trouble and not getting upset and so forth, that is absolutely where we want to be able to keep them. And so this idea of what's the goal here, and again, Dr. El-Malik's article, I think, does a really great job of just describing how difficult it is for that patient when the dopamine overruns their ability to take in what we would think of as normal demands of society, and they really can't handle them, and then they start that downward cycle. So targeted case management's defined in the reg. It's what you would think. It's getting them in touch with every service that they need. It's doing a comprehensive assessment and then periodic reassessments because people change so much. It's monitoring and follow-up. Targeted case management already by reg is restricted to SMI adults. This is not everybody who comes in with any kind of behavioral health diagnosis. Moderate to severe substance use disorder, or again, the children with severe emotional disturbance. So they really need this long-term functioning. We were talking with Commissioner Lee back in January of 2020, so before COVID, about the problems we were having in getting targeted case management approved. And it's not every MCO. Some MCOs approve it on a really reasonable basis. Some hardly approve it at all. And again, there's that difficulty. If you happen to have the wrong MCO, you could be in big trouble. And we started talking about, we had some providers who had hands-on experience, and Commissioner Lee urged us to do a deep dive. So we put together a study group with Dr. Alan Brenzel, medical director from the Department for Behavioral Health, and a number of providers that really had hands-on experience. And we went to the data people at Medicaid and said, here's what we need to look at. Here are the, can we find some people that didn't have targeted case management and then started to have it for 6 months? And let's see what we can find out about ER visits, about filling their prescriptions, going in and actually filling the prescriptions. Can we get data from other sources about housing status and criminal justice? And we are in the midst of doing that study. I'm really pleased. Phase 1 has been finished. They've identified just over 8,600 Medicaid patients that fit our criteria. Again, we're starting with adults with severe mental illness. At some point, we'd like to go substance use disorder. We'd also like to do the children with severe emotional disturbance. But we are in the middle of this, and they are pulling that data. So I hope, call me back in a couple of months and see if I don't have some data for you, because I love it that the commissioner wants to look at their data and see, so that we can once and for all verify what we think is going on with people. We know that we can break the cycle of addiction if we can get people in right away. Here are our recommendations, and I bolded the first one because that's really, I was tempted to only put that as my only recommendation, but I thought I ought to give you some leeway. So continue the current suspensions of PAs for all behavioral health services, at least until the end of the year, till we know where we are with COVID. Maybe we have some of the results back from our targeted case management study, and let's evaluate then. If the data shows what we think it's going to show, and that is that targeted case management, among other services, has the good effect of keeping people out of trouble, whatever that trouble is, which is usually more costly to the system. And remember that most of our folks on Medicaid end up getting hospitalized at the state hospitals, so that the MCOs don't pay for that service because of the IMD exclusion. So we really need to look at what their incentives are for keeping people out of the hospital. If we can't get number one, and I only reluctantly give you some other alternatives, but the other is continue indefinitely the suspension of PAs for those targeted populations that are most at risk. For the SMI and SED population, targeted case management, assertive community treatment, and therapeutic rehabilitation. For the clients with SUD, medication-assisted treatment, outpatient therapy, and initial intensive outpatient or short-term residential, or at least do a system where you would exempt those services for at least 90 days so you get somebody in and you really get a sense of what you can do without having to do PAs. And I think we ought to remove all arbitrary preset limits on targeted case management because there's absolutely no data to support that. But let's remember number one is my best recommendation from the behavioral health community. And I am, again, thankful for you inviting me, and I'm happy to try to answer any questions. And I've got tons of data that I couldn't fit into my slides, or I would have been talking to you like I was at the SMI task force for 2 hours or something.
I don't believe you're surprising anyone with that statement, Dr. Schuster, at all. But I appreciate what you're saying. And this addresses, I think, a myriad of problems with managed care. And wouldn't it be great if we just had 2 or 3 managed care organizations to deal with instead of 6? I mean, I just had to throw it out there.
It would certainly be easier for providers to understand the rules and follow them.
Well, that it would. And for this particular element of the delivery system, it makes no sense to me whatsoever as why you have to have pre-authorization, because I would think denied care, delayed care is more expensive care. And but do you know how this whole system works?
I do.
Is, the more we can deny, the more we can delay, the more payments that the MCOs don't have to make. And you gave the scenario about spending an hour filling out authorization forms. Well, from our perspective, healthcare perspectives, yeah, we don't do that. That gives us an hour to see more patients, but you see more patients, that means you bill for more services. You bill for more services, and that means less money for the managed care organization. So it's a vicious cycle that we go through. But I think your points are well taken. I will tell you that I've had one conversation with one of the MCOs. And it may be one of the friendlier ones you referred to already, but they were not adverse to this completely. They weren't willing to give carte blanche privilege to this, but they thought there was some room for some negotiation. So I think that's some follow up on, but at least that's a starting point.
Yeah.
And maybe we can build upon that. But let's go to questions. First, have Senator Carroll. Senator Carroll.
Chairman, can you hear me okay?
Yes, I can. Thank you.
And Dr. Schuster, thank you for your presentation. And I can certainly sympathize with the struggles with the PAs. And something that your colleagues will be dealing with once the PAs are lifted is you may have a situation where they're having to do far more PAs all at once as a result of that suspension going away. And I know that's something that we're still struggling with from months ago. It's caused major issues in dealing with EPSDT therapy services and PPEC services for children with developmental issues. And so it's not only just the PAs, but there are situations where it's ongoing services where PAs have to be renewed. You have situations where kids leave an MCO for a different MCO and the provider gets no notification. So then you're providing services and then you have to go back and apply retroactively for reimbursement, and the paperwork just continues to multiply through those processes. And in our organization, we've had to up our staff. I basically had 2 people doing PAs and billing. We're up to 5 now. Some of that has to do with our numbers going up on the number of kids we serve, but the extra running items back through the system time and time again, it's just ridiculous what the time that takes. And my question is this: there was some conversation with the MCO, as Mr. Chairman said. I think there is some willingness to make some changes, but this was a few years ago about the possibility, rather than doing PAs on each individual client or person being served, but to look at the provider themselves and certify each provider. And they would come in, they would look at the provider, how they do business, their structure, their credibility within the field. And then once they're certified, then that PA process goes away. Are your thoughts, is that something that might be feasible within the mental health industry also?
I think it's an idea that is well worth looking at, Senator Carroll, and I appreciate your bringing it up. I always try to gather data, so I sent out the SOS and said, tell me what your experiences have been and so forth. And a number of, particularly the CMHC, said, it doesn't make any sense. Our denial rate is 1%, for instance, on SUD, because we so clearly follow the ASAM guidelines and those other guidelines and so forth. And it seems to me that if a provider of whatever type is able to demonstrate that they have the guidelines and they follow them and so forth, that they ought to be able to earn their way out of jail, so to speak, and be able to, at least with certain populations and certain services and so forth. I still am going to go back to number 1 as a blanket recommendation, but I would certainly be willing. And I think a number of these providers who feel like they're doing a good job would certainly be glad to talk with you all and with the MCOs about that. Yeah. I like the idea.
I certainly wish that's something we could do. I mean, we talk about the shortage of revenue in Medicaid, and there's no question about that, and more people that need to be served, but yet our systems are set up to where it costs more, and it's costs that aren't, as has already been stated, not directly related to services. And I do think we can do much better in that, and I think we could do even better than that if we did reduce to 2 to maybe 3 MCO providers. Thank you, Mr. Chairman.
Thank you, Senator Carroll.
Thank you, Senator Carroll.
Representative Wilner, you have a question or comment?
I do. Thank you, Mr. Chairman. And Dr. Schuster, thank you for this testimony and this information, and for the recommendation to suspend the prior authorization for these populations. And I just, we know that there's been a spike in overdose deaths throughout the pandemic. And the CDC actually just came out with a report that had Kentucky number 2, only after Vermont, in overdose death during the pandemic. And I'm just wondering if you have a sense of how much of that might have been averted if we had, with suspending these prior authorizations sooner, and if that's also, strengthens your case for continuing now to suspend these.
Yeah, thank you for that question, Representative Wilner. And I think it's so difficult to know. We do know that people who are abusing whatever the substance is are not making decisions with everything intact. And we know that they are sensitive to all of the stresses that are going on. So if you look at a time like COVID that is so bad, I don't know how many of those people were at some point denied services. One would hope with the suspension of the PAs, our problem is that there are so many of these folks that are addicted that don't think to turn to services. They don't think that they've hit rock bottom or whatever those things are. And I do think some of those overdoses are accidental and not planned suicidal acts. So it's hard to know, but knowing that PAs put in a delay mechanism, one would argue that having no PAs for substance use disorders, particularly those that are already known to be moderate or severe, would make so much sense to not ever impose those PAs. So I'm gonna go with that as the best recommendation I can make. Thank you for the question. And we were very concerned. I mean, one of the things, and you all know, I know some of these people that are affected. We talk about the numbers, we talk about, the strain on providers, and we talk about the money, but the lives that some of these people lead is just unfathomable. And for them not to get the help that they need when they need it is just, it's heartbreaking. It is just absolutely heartbreaking. So I would hate to think that there was somebody out there who wanted to get into recovery and was denied that opportunity. And I think that's true also on the mental illness side, but more so, I think, on the SUD side. Thank you for your question.
Thank you. Thank you, Mr. Chairman.
You're so welcome. Dr. Alvarado, Senator Alvarado.
Thank you, Mr. Chairman. And Dr. Schuster, thank you. Just for Representative Wilner, I know you talked about MAT treatment, people with SUD. We did pass a bill to get rid of prior authorizations for MAT this year. So that's something that I think we can all take pride in. And it's definitely going to, I think it's going to really help, just because we had people that would come in on a Friday and say, I'm ready for treatment now. And if somebody's coming with SUD and needs treatment right then and there, what you had to say was, well, let me check with your insurance company and make sure I get approval. And you wouldn't get a response till Monday. And that person could go home, overdose, and die. And that happened time and time again. So we got rid of that, fortunately, with prior auths. To Senator Carroll's point, I think a better approach is, MCOs claim they're trying to get rid of people that are spending too much money on different things, and that people that are abusing the system. And there might be a few that do that, maybe less than 1% of the providers, but we're burning the whole system for that less than 1%.
Right.
I'd rather see an approach, Senator Carroll, where you'd have the top 5% of the most expensive people are the ones who are then subject to prior auths the following year. That'll keep you to try to, kind of challenge you against your own peers to try to keep your costs down, to make sure of that. But the other thing in a study that we need to figure out, Dr. Schuster, is how much money is being spent. We know the providers, as a practice, just outside of mental health issues, as a provider, I had 2 full-time people in my office that did nothing but prior auths.
Right.
And most offices have somebody either full-time or 2, or it depends how big your practice is. How much money would the insurance company save by not having a full system that does all of this, prior authorization? I mean, they're spending a lot of money doing that as well. I know there was one time where years ago, United Healthcare had done an analysis and found that they were spending more money than they were saving by denying services, saying, well, we're spending all this money up front, just get rid of the whole system, let providers do what they need to do, and they were actually saving money by doing that. So I think it would be wise for us, if we could at some point, to take a look, how much do the MCOs spend in overseeing, and then how much are they really saving in denial of services? And I'll bet you they probably are spending more to deny than they are just letting those services go through. So
I agree.
This goes beyond just the mental health issues, which is going to be striking right now, and it's a kind of a focus of this interim by several committees for us. But we really need to take a look at the entire system. Is it really worthwhile? Are they really saving that kind of money, or are they just denying care? Because I think ultimately you could probably find a much more targeted approach in finding your most expensive providers who might be spending too much and targeting them for oversight than the entire system. And we talk about shortages in providers in healthcare. I mean, if you could spend that bit of money on another provider in your office, you'd be able to provide a lot more services for people out there. So.
Instead of more fax machines, because that's what's happening.
It's ridiculous. Thank you, Mr. Chairman.
I agree with all of your points. Thank you.
Thank you, Senator. I think there's one piece that's missing from your financial equation there, and that's the investment off the float of those funds. And bear in mind that when I started in 2017, this was a $10 billion program. Today it's $14 billion. So there's substantial investment income to be realized by delaying payment as long as you possibly can.
Right.
And it may well offset the expense of denying claims or holding up claims. So
absolutely. I mean, we remind people that the interest that you can draw on that kind of money over 90 days or 180 days for denial of a payment is significant. And so, yeah, you're right. There's another financial incentive to do that. Agreed.
Representative Prunty.
Thank you, Mr. Chair. And some of this has already been discussed, but and the fact that prior authorizations affect all of healthcare, not just
exactly.
To me, you got to have accountability. Like Senator Alvarado said, abuses in the system, it might be a small percentage. Try to go after those. But so there needs to be accountability. I like Senator Carroll's idea of, but maybe there needs to be an annual review or something, because just because you get certified doesn't mean you might not go back and abuse the system. But I like that kind of approach. But I just remember my husband saying, once somebody's got a BKA, the limb ain't growing back, so why do you have to justify that every single time? So it's the same thing. SMI is a chronic illness, just like you said, diabetes. Yeah. So, but how do you get the this is a rhetorical question, but accountability for the providers for not abusing, because PAs weren't always a part of the system. It seems like in everything we do, we go from one extreme of the pendulum to the other. How do we get back to the middle for balance to get the goals that you need? So anyway, if there would be some way to, if you could come up with an idea of how to hold providers accountable in a situation, how do you do that without getting the person the service they need without allowing somebody to abuse? So it's just a rhetorical question right now, but maybe something we could brainstorm on. But thank you, Mr. Chair.
I wonder, Representative Prunty, because so many of our CMHCs are accredited by outside bodies, either JACO or CARF, and they have periodic reaccreditations and so forth. So there is at least some accountability for a good number of them. Also, I think some of you heard from Steve Shannon yesterday at the SMI task force that 4 of our CMHCs are going to be CCBHCs, which are kind of CMHCs on steroids, with a whole lot more ability to manage patients and so forth, but with a whole lot more accountability built in. So there are some external mechanisms in place, at least for some of them. But I think that's a piece. Obviously, we've got to have that. And it's very hard to measure outcomes in behavioral health. You don't have an x-ray. You don't have a blood test. It just is harder to measure those outcomes.
Thank you. Thank you, Mr. Chair.
Thank you. Representative Sheldon.
Enough has been said. I think we all feel the same way. There's a lot being said, and I could talk forever on this subject, but I won't. I just want you to know, as a provider, you watch the way healthcare has migrated to folks like the MCOs that the provider is not able to provide care. You know, I would much rather the MCOs focus on the organization part of it. We needed people at one point, and still do, to organize these bundle of services, and there's a function there. But when they got into the care and continued to dip into the care and explore the care that the provider, I'm talking about provider care.
Right.
See, the provider has lost that control. So in so many cases, no matter what type of health care you're receiving, you're being told, like you said, 5-6 MCOs that are giving you 5-6 different sets of criteria for just about every type of health care there is. So I am on board with what you're talking about. I won't talk about number one. I mean, I like number one. I think it's perfect. So I won't go down and talk about the rest. So no, you're good, and we're going to stick with that one. All right. So I won't talk with the other ones.
That's great. I better quit while I'm ahead.
That's right. That's right. Thank you very much, Doctor.
Well, I will say, because of your pharmacy background, that taking away the ability of the prescribers to prescribe what that person really needs is just wrong. And it's so wrong in so many areas, but it's particularly a problem with our folks with severe mental illness. And I applaud Representative Moser and Senator Alvarado for trying for several years to get the MAT PAs removed for just that reason. But as you know, at the pharmacy end, Representative Sheldon, providers are being taught what to prescribe because it's what they can get through the system, and it's not necessarily what they know that patient needs, and it's just a constant struggle.
I think that's a great point. So much of what people are getting is because the provider just doesn't have I wish I had a nickel for every time I got a call saying, what's covered? What's covered? Because they just don't have all this time to do the PAs. So it's just it's a tough situation. So thank you very much, Doc. Appreciate it.
Thank you.
Well, you've followed our committees for several years now, and you probably know that Representative Sheldon and I are kindred spirits, and we say brothers from another mother. And I would hardly embrace that first recommendation as well, but you wouldn't hope we're not in session right now, so we don't have authority to do anything other than suggest to Medicaid that we continue this, which I think we would do. But I would think the next point or next position we should take is to have the cabinet come next month, if Co-Chair Elliott's agreement, as well as the MCOs. I'd like to hear if, their take on this. And they have in the past tried to extend an olive branch to me, saying they want to work with us. This could be a good litmus test for all of us, is what's this going to look like going forward. So I think you have some excellent recommendations there. I will certainly embrace them. I know probably folks from Medicaid are listening in on this today, and hope they're paying attention. But we'll take this up next month, Co-Chair Elliott, if you would agree, and we'll pursue this. But I understand the importance of it and appreciate your testimony this afternoon.
Thank you for giving me the opportunity. I appreciate it very much.
Before you leave, Co-Chair Elliott has a question for you.
Thank you, Dr. Schuster. Near the beginning of your presentation, you talked about medical necessity that was attempted to be defined in legislation, I guess, in 2018. So I was around in 2018. House Bill 69. If that is defined at some point, does this alleviate some of the problems that you have testified here about?
It would make it less arbitrary and less changeable from one MCO to another. And that was Representative Ken Fleming's bill, so it might be helpful for him to come and talk with you all about it. It had two pieces. One was the central accreditation or credentialing for providers, but it also had this piece, and they were giving it to the Department of Insurance to come up with that medical necessity. And you get into the MCOs saying, we use a proprietary criteria that can't be posted someplace. And then I think there actually was a lawsuit, as I recollect, that stopped them from doing that. But it would help. At least everybody would know what the rules were, and it wouldn't be so changeable over 3, 5, 6 MCOs.
So each MCO has their own definition,
and then they apply it each in a very different way. Yes.
Okay.
Yeah,
okay.
That's the issue.
Thank you so much.
Thank you, Dr. Schuster. Appreciate your testimony today, and we'll get maybe part of an answer here today, or at least some additional information, because we do have Veronica Judy Cecil, Deputy Commissioner for Medicaid, to testify, as well as Leslie Hoffman. So if you folks are here, are we doing this remotely? You folks are remotely. If you would identify yourself for the record and please proceed.
Absolutely. Good afternoon. This is Veronica Cecil. I'm Senior Deputy Commissioner for the Department for Medicaid Services.
I'm Leslie Hoffman. I'm the Chief Behavioral Health Officer for the Department for Medicaid Services.
Thank you. Sorry, I don't know who's going first, but please proceed.
Thank you. And I think we're waiting. Our understanding is that I guess somebody's going to put up the PowerPoint slide for us. So
we can do that, or would you prefer to run your own PowerPoint? Share screen.
Yeah, we're absolutely happy to do it.
Okay.
So Leslie, are you going to share yours?
Yes, I'll get it.
Okay. While she does that, just a few things to kind of set the stage for our presentation. We were asked to bring some very specific information and data, and so that's what we have in our presentation. We also want to ensure our members are getting the services they need. And that's, if you know Commissioner Lee, that is her #1 priority. The other thing she wants to do is make sure that we're making policies decisions that are data informed. We really want to look at our data and try to determine, are we seeing the outcomes that we should expect? Are we properly measuring those services that are being delivered so we can determine what the outcome is? A couple of things to know. Dr. Schuster mentioned that we're working on targeted case management. We have a work group on that. And, we feel like that really is a perfect way for us to take a look at some of these services, make sure that providers, the MCOs, and the department all understand what the service is, how should it be delivered, is it being properly provided, is a PA required? I mean, those are the reasons we're looking directly into that. For the data we're presenting today, I just wanted to note a couple of things. One is we're presenting data based on the date. Prior to the pandemic, we had MCOs prior authorized services differently, as you all have been discussing. So some services, one MCO may prior authorize, but another MCO may not. So it's really difficult sometimes to get down to as this service was prior authorized by everybody or it wasn't, because there are differences in what is prior authorized. I also want to note, we do put it in our managed care organizations, we dictate what the medical necessity criteria is. So for instance, as Dr. Schuster mentioned, for substance use, we dictate that MCOs are to use the ASAM criteria. We also dictate for services either Interqual or Milliman. And if those don't cover a behavioral health service, then we further dictate the criteria that the MCO is supposed to use. So I wanted to make sure everybody was aware of that. When the pandemic hit, we quickly moved to telehealth. But as noted, some services really need to be delivered face-to-face. And so I think we've worked definitely over the last year and a half with the different provider types and the different services that are being delivered to try to determine what works best, what's appropriate. In the beginning for behavioral health, some of the service couldn't be delivered through telehealth, but professional standards changed and allowed for some of those services to be delivered. So we're very much eager to cover those services to ensure that our members are getting the services they need. So with that, I will walk through the data and then certainly happy to take questions.
So I'll just go ahead and get started. So we're comparing today the behavioral health service utilization with and without prior authorization, which was pre and during our public health emergency. This is a list of our behavioral health Medicaid covered services. As Veronica and Dr. Schuster have mentioned, most behavioral health services required a prior authorization before the public health emergency, but all have been removed during the public health emergency and continue to be removed today.
Excuse me, but I don't think your slides are advancing. We're still seeing the first
Can you
page.
see it okay?
It,
Okay,
I can
now
see it, but it's not advancing.
it's advancing for me, so I'm sorry. So I should be on slide 3 now.
We still see slide 1.
Huh. Okay. Don't know.
If it
says
works better
3
for you, we can do it from here, but you need to tell us when to change slides.
Sure, that would be fine.
Okay.
I might just have a delay from Taylor County.
This is the price we pay for being slave to technology.
There we go. Okay, so this is slide 3, and this is the utilization of behavioral health services with prior authorization. Just like Veronica said, we ran this report April the 1st of 2019 to March the 31st of 2020. And I wanted to make it very comparable for you. As you're aware, we do have some delays in our payment and claims and reporting. As you'll see here, the members are 1,630,891, claims 4,227,651, and the total cost is 541,628,257. So the slide just right below it says the utilization of behavioral services without prior authorization, and that would be the following year up to March the 31st. And that's not up to today, that's up to March the 31st because I wanted to give the best comparison I could. You'll see that the members are 1,559,336, claims are 4,642,745, and the total cost is 591,764,893. And then on the next slide that shows the differences. So our member count actually went down, but those receiving services, the claims went up, with the total cost, of course, going up. One thing I would like to mention is that when the public health emergency first occurred, there was a delay we saw in providers billing for about 6 to 8 weeks. And I believe that was probably where the providers were trying to, this is how I operate today. And now I've got to learn how to operate in another way. And what does virtual look like? What is my capacity? What staff do I have? What platforms? Who can do this from home? Those kind of things. So we did see a lag for about 6 or 8 weeks, and then that started picking up. So with that said, I think this is one of those reports, this information is one of those reports that as we keep running it, it will become more accurate. And again, I was only able to pick up to about March the 31st for this year. Next slide. We added this in. Senator Meredith, I thought you might be interested in this. This was the behavioral health expenditures by provider type with and without PA. So this is a percentage of change. And so the percentage of a change is the relationship between the original amount and the amount now. So we call that a percentage of change. It's a formula that we complete. So as you can see, like the community mental health centers that Dr. Schuster spoke about was a negative 13.5. I did list on this page and the next page a variety of ones that I thought you would be interested in, but I did not list them all because there's probably about 50 on the report that I ran. So if there's something specific you're looking for, you can proceed to the next slide, please. That's just the second page. So one of the things that I've mentioned too is the PRTF and any of the inpatient residential type of settings. It seemed like they had a decrease during the public health emergency. any of those that were one-on-one or any of the licensed services by practitioners seemed like after they caught on to the virtual piece, and it seemed like those were all going fairly well. So I think that's it. Proceed to the next slide, please. Yeah, that's it. So those, that was just in a nutshell for you based on the ask of Medicaid, but I'm always willing to drill down or look at other things if you want me to. And I work well with Dr. Schuster, and she knows that I respect and appreciate her. And I'll follow up in any way you need me to.
Appreciate that. Good information. I think probably the biggest question hanging out there is how much of that increase is what I would call COVID induced. That it certainly has put stress on folks that we've already acknowledged, and it may be a 2 or 3 year period before we can really get a good handle on what the impact of this could be. But I do appreciate the information. Representative Prunty, you have a question?
Yes, thank you. This question is for, Veronica? Yes, Veronica. You said that Medicaid dictates using the ASAM criteria. If Medicaid dictates that, then what's the problem with the MCOs if they're doing everything different for each? Why all the confusion? And are they just being allowed to do it? I mean, if you dictate it in the contract and they're not doing it, is there any consequence for them?
There absolutely is. And you know, I think the difficulty, so some of it obviously is inconsistency of what is prior authorized and what isn't, because we don't dictate that. So if a MCO wants to prior authorize targeted case management, for example, and my understanding, there were only 2 MCOs prior to the pandemic that prior authorized TCM, but so we do give them the ability to make the decision as to what services they prior authorize. So there may be confusion over that. And then there are 2, you know, especially for the physical services, Milliman and Integral are the primary, and I don't think that's any different from in the commercial world. But you know, beyond that, then we definitely, for both adults and children, we dictate what is to be used. So, you know, we hear about providers struggling with understanding what the criteria is. We try to deep dive into that. And part of that is monitored through appeals. You know, we definitely monitor appeals to see what are the, you know, top issues that are going on that helps generate our inquiries to the MCOs to make sure they are utilizing the appropriate medical necessity, and then generally through complaints that we receive. So, you know, when we do receive a complaint from a provider saying that the MCO isn't or has created their own criteria, you know, we go back and make sure that the MCO is doing it appropriately.
Well, for a follow-up question.
Yes, please.
So maybe you just answered the question. Maybe y'all need to, I mean, I'm just thinking out loud, but maybe y'all need to determine whether they are allowed to prior authorize or not, so that they're all playing the same game by the same rules. I mean, that's what's so bad for everybody. But that's just
right.
A thought. That's just a thought. And just a follow-up comment. I know Dr. Schuster said that stabilization is the goal for the mental health, and it was a decrease of 521% over that year. So that's significant. So anyway, just a comment. Thank you, Mr. Chair.
Thank you. Senator Carroll, Danny Carroll, you have a question.
Thank you, Mr. Chairman. Commissioner, in getting not really so much on the mental health field, but with EPSDT, in dealing with PAs, we've had this conversation before, and I think I've brought it up pretty much every year I've been in the legislature. EPSDT services, therapies, PPAC, are my understanding, and I know I've had a former commissioner actually state this in committee, that the MCOs do not have the ability to deny these services. With the PPACs, there is a leveling tool that comes from the cabinet that is completed. All of these services are provided upon prescription from a physician, but yet year after year, the MCOs continue to deny these services based on medical necessity, and nothing changes with that. Can you comment on that, and why is that still happening? And it's just another one of those things that just takes more time to get the process through to be able to serve all the children that need to be served, and the MCOs use this as a way to avoid payment, and therefore the whole purpose of EPSDT to give the children what they need as recommended or as prescribed by the physician who knows the children and knows the issues that have and know what their needs are. Why is this still happening with the MCOs?
So as you pointed out, EPSDT services do have to be prior authorized because there has to be a determination of medical necessity in order to comply with the federal requirements. So all of those services have to be prior authorized. With denials, there should never be blanket denials. And if that's happening, again, we would see that in the data. I would hope we would see that in the data that reflects that, so that we can then check in to see what's going on with that. And we always look for examples. I mean, I think the most difficult thing that happens is that we hear there are problems, but we can't see it in the data. We can't hold the MCO accountable unless we have examples of what's going on. We just can't do it anecdotally. So we're always, and I know providers get tired of us doing it, but we're always asking for specific examples so we can go back and trace it through the process, trace it through the system, and try to determine what is going on, because that's the only way we can hold them accountable. But I agree with you. I mean, I think reoccurring denials or blanket denials are not appropriate. It should be based on the individual and that individual's need. It's about the member and the services that they need. And that's what we always strive to do.
So within the MCOs, do they have the ability to override a physician's prescription or a therapist's recommendations on what the child actually needs?
They can evaluate and make that medical necessity determination, but that's why we have an appeal process, and that's why you all passed an external third-party review opportunity for providers to be able to push back on those denials.
Okay, that has not been my understanding at all of the way EPSDT works. That they did not have that ability, and former Medicaid commissioner said that in open committee back a couple years ago. So that's a little confusing, and that's just not the way I understand it at all. And it's not really so much blanket denials from what I'm getting, from what we deal with, from what other providers deal with. It's just in the numbers of therapies that they feel are needed. And again, these are doctors that have nothing but notes in front of them that don't see the children. So that's a little concerning in itself, and not the way I understand EPSDT. But thank you for your input.
Thank you, Senator Carroll. I have a question from a couple more, but let me pose one to you. Given the testimony you've heard today, and given the fact that we're seeing an uptick in the COVID virus due to the Delta variant, have you all had any discussions about continuing this through the balance of the calendar year?
So I did want to mention, if you were not aware, but the Health and Human Services Secretary did extend the public health emergency. He can only do it for 90 days at a time, but we're happy to hear that it has been extended, because it does give us a lot of flexibility during this time. And I wanted to explain about during COVID and what we've been doing with prior authorizations. We took them all off at first, and we allowed for some of the medical side, the physical side, to come back on. But that was after, I can assure you, close review and a deep dive into the data at the time. We do not want to create barriers to care. So with behavioral health, we continue to evaluate it, and we've determined that we're not ready to put a PA back on yet. And during this emergency, knowing the behavioral health impact of COVID, I can't say we're going to do it through the end of the year, but we're going to continue to evaluate it. And we understand the door that has been opened for folks to get the services they need as a result of it.
Well, certainly the reason this was agenda item today was talk specifically about the PAs, and we've kind of gone beyond that, and there certainly are some issues that need to be discussed further, but even with the extension for another 90 days, I would recommend to the committee that we invite the MCOs here to talk about this and try to get all these issues on the table. But I'm very pleased to hear we got additional 90 days. But Senator Alvarado, you have a comment, question?
Just question real quickly. Do the MCOs report, Commissioner, do they report to you all their denial rates? I mean, because I'm looking at, you've got about a 10% increase in claims, $50 million more in costs, less members. Do they report to you every year what their denial rates are on these services?
Claim denial?
Well, yeah, or denials on prior auth. If somebody requests these services,
yes.
say no. What are their denial rates typically per year?
I apologize, I don't have it at the top of my head, but we do get reports on their PA, the prior authorization rates.
That'd be worthwhile to know, because we'd probably get back into that data off of these numbers from the year-to-year comparison. The other thing is also the extra $50 million of cost for this. Did that come out of what the MCOs have allocated? Did the cabinet pump $50 million more from federal funds? How do we absorb these costs for the increase in the past year?
Well, that's the beauty of the capitation payment. We pay a capitation to the MCOs, and they're required to spend 90% of what they receive on healthcare services. So they are held to a 90% medical loss ratio. Our actuary does evaluate, if we would see a significant increase, based on COVID, or we've added a service, then our actuary will take that back and look to see if there's a need for any changes or an amendment to the rate. We've not seen a need for that yet, but we are always evaluating it.
So that's very important. So this $50 million comes out of the capitated amount the MCOs have received. I'll be curious to see what their medical loss ratios look like this year. If they're at 10%, which many of them often put that out first and then do the rest back-ended in, if they're able to meet their same losses, or if they're going to be operating at a negative amount. If they're not, then that would give a pretty good argument to continue what we've been doing and seeing. And is it really producing, the kind of losses that they're going to claim? Because often when we have these kinds of discussions, the claims from the MCOs are, well, hey, listen, we have to provide services within this amount of money, and we can't do it. If we've added $50 million in the past year and their medical loss ratios don't look any different, or if they're still profitable at large amounts and able to maintain it without the prior auths, that makes a pretty strong argument to get rid of this process altogether. So I'd be curious to see what those are, the denial rates, because if they're spending a lot of money denying these things and really not going to affect their profits at all and still be able to provide the care and provide more care for folks and less hassle to our providers, that's a win-win for everybody. So if you got the denial rates, that'd be good information for us to have. And if this was absorbed by the MCOs, to see how their profits look like this next year will be interesting to see. Thank you.
Thank you, Senator. Last question on this subject, Representative Wilner.
Yep, thank you very much, Mr. Chairman. I'm given the testimony we heard earlier, I'm trying to sort of wrap my brain around MCOs setting what seem like arbitrary limits, like no one should get more than 12 months of targeted case management. And so that's, not part of the medical necessity criteria. And so I'm just wondering who is putting those restrictions in place.
So you're correct. All services should be based on the individual's need. There should not be arbitrary limits. What might happen is that an MCO may authorize a certain period or a certain amount of services, and would like the provider to come back and so they can do a check to see, well, what's going on? Is there something else we need to do? Are they at the appropriate level? So that conversation can happen. we do tell MCOs that you cannot just set an arbitrary limit. So if they hit 12 and say no, and we have no limits in our state plan, then that's not appropriate. And we do have those conversations with them sometimes when we can see that happening. And again, a lot of that's based on provider complaints and making us aware of it.
Just a quick follow-up, if I could. I mean, what is the best recourse for providers and for people trying to get services when they run into those barriers?
It's to appeal. It's to afford yourself of the appeal process. They're both on the member and the provider side. And again, we closely monitor that. We are always looking at how many appeals are coming through, what are the top reasons. And we go to the MCOs and we have those conversations with them about what's going on to see is there something systemic happening with that.
Well, we'll look forward to having that discussion with them when they appear before our committee as well. I think there's a lot of questions that need to be answered. And as we're entering into this RFP situation with the MCOs, I think now's the ample time to do it. So appreciate everyone's questions, appreciate the testimony today and your time, and we look forward to continuing discussions on this. But thank you for your time. Appreciate the information. Moving right along, next item is the Kentucky Trauma Network, and Mr. Bartlett is here along with excuse me, Dr. Kosich. Glad to have you both in person this time.
And Andrew Young is here with the Department for Public Health, Director of Administration and Financial Management.
Thank you. Dick.
My name is Dick Bartlett. I'm the trauma coordinator working for the Kentucky Hospital Association. We're on contract with the Cabinet for Health and Family Services to provide. Okay. Hi, I'm Dick Bartlett. I thought the light was on, sorry. I work for the Kentucky Hospital Association. I'm the trauma coordinator. We're on contract with the Cabinet for Health and Family Services to provide assistance and support for the trauma program. And I made the presentation on the 7th, but that was more on the trauma fund. This presentation will be driven around the data and its impact on the trauma system and the Medicaid system. And Dr. Kosich is prepared to deal with that. She's representing Kiprick.
Glad to have you both here today. I asked this to be an agenda item in the report that Mr. Bartlett gave a couple of weeks ago, or last week maybe. Time flies, you're having fun. Was to our budget review for human services. And most of you know that we passed this legislation back in 2008. It never has been funded. So while we have a trauma network, we really don't have a trauma network. And I think there's some real implications, negative implications for us because that doesn't happen, particularly for the Medicaid program. So the reason for this testimony today. So glad to have you. Please proceed.
Thank you so much for this opportunity. My name is Julia Kostic, and I have the honor of being the elected chair of the State Trauma Advisory Council. I'm also the Associate Director of KIPRIC, the Kentucky Injury Prevention and Research Center.
Could you push your microphone a little bit closer to you?
Right, and I teach at
Thank
UK, and I want to acknowledge our epidemiologist, Laura Daniels, who prepared some of the data in this presentation. So I'm going to, as succinctly as possible, recap Dick's presentation from the 7th of July for those who haven't had a chance to look at it, and look at some trauma system data and its impact on Medicaid, as well as Medicaid's impact on the trauma system. So the trauma system, and this is from Dick's presentation from July 7th, but I want to point out that we're talking here about physical trauma, so we're changing the focus from the behavioral health focus of the previous presentations. In KRS 211.490, I want to note that even in 2008, there was a legislative finding that trauma centers save lives and money. There is a lot of literature on this subject, some of which I will be happy to review. The trauma system has never really been funded by the state. We did have some money, thanks to Commissioner Mayfield several years ago, from unencumbered federal pass-through funds. And the National Highway Traffic Safety Administration provides us with 1 year at a time funding to support the state trauma registry. So you know that trauma centers have to go through what we call a verification process, and there's lots of literature on state trauma systems and their contribution to outcomes from serious injury. Once again, trauma for these purposes is a life or limb-threatening injury that you have to deal with. People talk about the golden hour. Ideally, for these serious injuries, individuals would reach definitive care within 60 minutes. That is not, unfortunately, always the case. There was a study in Arkansas, which is relatively new to the trauma system world, that found that a $20 million investment by the state to establish a trauma system yielded a 9-to-1 return. This return on investment was in terms of lives saved, not perhaps the kind of numbers that you folks are, ideally focused on, but it's still an important point. Once again, lots of literature on the value of trauma systems. It's also important to note that access to post-acute rehabilitation services, whether as at an inpatient facility, as outpatient services, at a nursing facility, or provided in the home, improve outcomes. And I want to emphasize that because that is an important nexus between trauma systems and Medicaid, particularly expanded Medicaid, as we have in Kentucky, because the archetypal serious trauma patient is the very kind of individual who historically was not eligible for Medicaid, and that is the young adult male. So the trauma system payer mix. I could talk about this all day, but I won't. You can see that a slight majority of the trauma system payer mix comes from various government funders, including Medicaid. 38% is from commercial insurance, and 6% is what we euphemistically refer to as self-pay, which typically results in very little, if any, funding. It's important to note that before Medicaid expansion, that category was often as high as 40% of the trauma payer mix. I've got these slides backwards again. So I want to point to this very useful map from our colleagues at the Kentucky Transportation Center, which looks at fatal crashes by county. This is a highly aggregated metric, but this is the standard metric. So you can see the dark blue, dark navy areas. Those are areas with seriously elevated fatalities. These are fatal car crashes, okay? Once again, this is a highly aggregated kind of metric, but there is a huge difference across the state between the kind of pale turquoise counties and the very dark counties. This is a fourfold difference in fatality rates. So if you look at where hospitals are currently in the state trauma system, and I thank Dick for this map, that you can see that this doesn't quite match where these fatalities are. Some of this has to do with the population in these areas. I am pleased to report that we do have, can you see the cursor? We do have some talks going in this far western area, which is a high incidence area, and also in the south central area with facilities that we are hoping will be joining the trauma system before too long. Now, some of the areas that have no trauma hospitals have places right across the state line. Cabell Huntington, I think you're probably familiar with. The Cincinnati hospitals have trauma services. Also, a lot of people from the southern tier of counties do go to Tennessee for trauma services. So, lots of car crashes and fatalities in Kentucky. Some of this has to do with topography, frankly, but it's important to note that the large majority of motor vehicle crash-related deaths today are scene deaths. They are at the scene of injury. They are not deaths that occur once the person's gotten to the hospital. And in fact, once trauma patients get to the hospital, they are very likely to survive, which is, once again, another reason why having access to post-acute services is so important. We see a similar injury pattern over time in the military, if you know anything about military injuries, that a lot more people survive these days, but with very serious injuries. Trauma care is very expensive. Part of this has to do with the types of patients we're talking about. A non-trauma center injury patient is likely to be an older female patient with Medicare coverage. The typical trauma center patient, once again, is a young adult male with Medicaid or, as we say, self-pay or uninsured. And the injuries are much more serious in trauma center patients. So trauma centers are expensive to operate, but it is important to note that trauma systems can save healthcare costs by reducing variation in care, by reducing repeat imaging, which is a huge cost in unsystematized trauma care, with reducing the need for air transport, which I'm sure you all know is just extremely expensive, and by monitoring quality of care. Trauma systems are accountable to their verification authorities. So this is once again from our friends in Arkansas. These are 2014 estimates. I have not attempted to inflate them or do anything fancy with them. This is just multiplying the extent to which costs exceed reimbursement by level of care. The dollar numbers are from the Arkansas study. I think Arkansas is close enough to what we do in Kentucky. I mean, we're not talking about New York or California, that at least we can relate to it. And then the number of patients are Kentucky numbers. These are patients with lengths of stay of 2 days or longer, and most of them quite a bit longer. So you can see, if we use the Arkansas numbers, that the trauma system care is not a moneymaker for these hospitals, particularly for the level 1 centers. With regard to access to post-acute care, it's important to note that Medicaid has supported a substantial increase in access to post-acute care, and in the interest of time, I'll skip most of this because I think I may be telling you stuff you're very familiar with. But if you look at the last bullet point, seriously injured patients, patients with injury severity scores above 15, the discharges to post-acute care increased to verging on half of these patients. And for some of these patients at the point of hospital discharge, they're not actually ready for much in the way of rehab yet. So their ultimate access to rehab is probably higher, but because of the nature of trauma registry data, we aren't able to link patients across care sites. So other ways that trauma systems help save Medicaid, and Medicaid helps save trauma systems money. With Medicaid expansion, patients have access to more routine outpatient settings. They can actually go to a clinic or to a doctor's office instead of fetching up at the emergency department with the injuries that do not require hospital-based care. And by reducing the proportion of uninsured trauma patients, Medicaid expansion helps hospitals actually get paid, Now, arguably, maybe not enough, but at least they are not looking at a 40% uninsured rate. I need to point out trauma registry data record encounters of care and can't be linked across care sites by patients because they are de-identified as a matter of state law. So in summary, we have a lot of traumatic injury. We know that trauma systems reduce death and disability from traumatic injuries. Medicaid can benefit trauma systems, and conversely, trauma systems benefit from Medicaid expansion. I should point out, and this is a subject possibly for future discussion, many states have developed sustainable state funding models for their trauma systems. If you want to know about that, once again, this is a somewhat different topic, but I'm happy to discuss them. Trauma systems need oversight. They need administrative support. They need people like Dick Bartlett here, who, with the best will in the world, is not going to be available to do this forever. It's expensive for hospitals to participate in trauma systems. We are deeply grateful that they do, but we only have 27 reporting to the state trauma registry out of 93 hospitals in the state. So it's a distinct minority. We have the potential to add hospitals. We have to sometimes sweeten the pot, but we do what we can. And being an academic person, I have not just a list of references, but also a disclaimer. Any mistakes here are mine alone. This presentation has been reviewed by a bunch of people, and I appreciate all their input. So with that, I am delighted to answer questions, and I'm sure Dick is as well.
Thank you. I appreciate the presentation. You've done exactly what I asked Mr. Bartlett to do, is to tell us how this could save the Medicaid program money. And the folks on this committee, I'm sure they're tired of hearing me say that, I think the Medicaid program financially is the biggest it ever should be. Right now it's at $14 billion, and there's enough money there to take care of everybody if we spend it the right way. And by not having a trauma network in place, there's a cost associated with that. So that's the point I'm trying to make, is by making this investment, we can save the program considerable dollars. But we'll start with Senator Alvarado.
Thank you, Mr. Chairman, and thank you for the presentation. This is something that's been presented to us so many times before. I mean, begging for the funding to help fund the system. Two principal questions. How much money would be the ask right now for the budget if you were to ask for that? I know we're not in a budget committee, but I'd like to know, because I'll probably put in the request nonetheless, of what we're looking at per year. Is that $4.8 million amount that you posted earlier as far as the loss, or because it's grown a bit from years before when we've had that presented?
This gets to the presentation we did on the 7th. We've looked at this. We did some strategic planning of this thing, and it depends upon how far we want to go. In our strategic planning that we did a number of years ago, we actually come up with a proposal that gets to about $1.2 million. We didn't think that would be a reasonable ask. We didn't think that would fly. So what we presented on the 7th was a proposal that looks like $321,000, roughly. That would support the trauma registry, the trauma data analyst, some educational programs, outreach activities. It would support, because right now I'm kind of in a limbo funding situation. In our situation here, it would support a trauma coordinator, and it would help to support our trauma symposium, our educational efforts, and those are the kind of things we're looking at. Now, if we get into a little more ambitious program, the chairman has an associate that left his hospital and went down to Georgia, which has a very innovative super speeder program. And they've gone to the point where they've actually created additional funding to provide stop the bleed training and kits in public schools. They are providing additional targeted education to EMS. They are helping to create stability in the trauma system. They're providing some reimbursement for that unreimbursed care. So I think it depends upon how far we want to go with it. Like I said, we tried to be reasonable about this. We're just trying to get some money into the budget to provide some stability for a program without any money. As I said in the last program, I'm 74. I'm not going to do this forever. But I am all you've got. Trish Okeson is my anchor, at the cabinet. She does a great job. She was there with Dr. Hacker. And Dr. Hacker said basically, I will support the program, but you are going to have to raise it. And I've tried to do that since 2008. But I'm not going to do this forever. But if I decide to step aside, or God forbid I get hit by a car on the way home, there is nobody. We need to provide stability for this trauma system to help it and to continue it and to grow it. And I would love to take the approach that Georgia has done. I think it's been very innovative, it's been very helpful, and it's provided some tremendous stability for their program. And I think we need to look at the short term, and then we need to look at some longer term issues to fix this problem long term.
And I know Georgia, I think they charge extra per speeding ticket. I think it's an extra $200,
Yes, sir.
and every time that goes into the fund. The second thing, if you can go back to your fatal crash rate, I just found it just remarkable. If you want to pull up that map with all the counties, the turquoise, and this is by where the accidents occurred, or is it where the people reside that were involved in the accidents?
This is where the accident occurred.
So I find it so interesting because I think I see the two lines. I see where Interstate 75 comes straight down, and those are the least. And that would be contrary to what I would think. I would think intuitively you would have where the interstates run, you'd have more accidents. But Interstate 75 runs straight down that very light turquoise, and 64 almost entirely across there, with the exception maybe of Clark County and Montgomery, the same thing. And I found that interesting. So a lot of these are happening obviously in back roads, smaller roads, where there's interstates and probably higher velocities. We're not seeing nearly as many accidents in off of small ones. So I was just curious. I found that as an interesting point of observation just looking at the map.
But think about the western Kentucky area. The dark area there is Interstate 29 heading down towards from Paducah and those areas down south. You've got Interstate 65, you've got Interstate 75, and then you've got the band across the center, down in the south center area, is the Parkway that runs between Bowling Green and those communities across the southern tier. So these are the areas, and I think it has to do, quite frankly, with the speed. And then if you'll flip to the next map, Julia, the one we did of the maps, the problem that I've got is that I'm trying to develop trauma centers to help in some of those areas. In western Kentucky, I had a couple of, and they've backed away. We're going to do a trauma development course down there in November. My regional coalition down there is going to lead that. We're going to try to instill some interest and growth in that particular area. We had a trauma center in Madisonville. They chose years ago to opt out. We'd like to try to encourage them to come back. Warren County Bowling Green Medical Center has stepped up. They are interested. We're going to try to, again, fill in some of those gaps along the Parkway along in the south. And we're going to try to fill in a couple of those in the northeast. But, you know, this is a tough situation because, as we said, this is not a money-making proposition. Now, I'll be very honest with you. There are a couple of states where a couple of systems have really leveraged the activation charges and have charged a great deal of money and so forth. We don't have that situation here. I've got trauma centers that are not using the activation charge. They're doing it because it's the right thing to do. They're doing it because it in the mind of their public, it makes their facilities step up as a little bit better than the rest. They're doing it because it's the right thing to do. And I appreciate that. And so we're going to try to encourage that. As I said, I've got 3 and probably 5 facilities that are in the development stage. They're either in the just beginning or they're actually submitting data to Julia's registry. We require them to have a full year's worth of data. We want to make sure that they're doing it and they're doing it right. And when we come in to verify, or the College of Surgeons comes in for the higher level ones, we want to make sure that what they've done is going to stick, that the process of quality improvement is there and it's real, that the trauma advisory committee that they've got within their own organization is looking at cases, learning what they did right and wrong, applying those lessons, and making the system better. It's a constant improvement process. So we're working on it. It's a long-term thing. This isn't, a quick game. We're in this for the long run.
Senator, I'm going from memory here, but I think the Georgia program is $23 million, and it's funded exclusively through their super speeder program. Mm-hmm. So I think that's a reliable funding source. But I concur with Mr. Bartlett's position on this. If we can go possibly a $500,000 ask this time and kick this thing off and work on legislation for the funding, and again, I would hope it would go towards the super speeder initiative, because I think that makes sense.
Or something. I mean, some states do other ways of doing it. This one just seems to be a process that wouldn't hurt the average person. I mean, if you're going If you're going to go, 25 miles over in a residential area, you deserve it. If you're going to go 90 in a 70 zone or 95 plus, which some of them are out there doing, and it's gotten worse during the pandemic, then I'm sorry, you deserve it.
And I'm sure there's direct correlation between high speeding and in trauma cases, and it's consistent with my philosophy. If you're going to juggle chainsaws, you should be paying for you lose your arms. So that's my thinking. But I appreciate your testimony today, and hopefully maybe this will be the last time you have to do this before us, and we can move this thing forward.
Not a problem,
Appreciate
Senator.
your commitment to it. Thank you.
Hoping Dr. Alvarado doesn't have to hear this again.
I'll keep advocating for it. I'll be perfectly honest.
Thank you, folks. Appreciate it. Last but not least today is our Medicaid pharmacy benefit integrity. And the folks we have presented today actually presented a couple of years ago, and thought it was a very interesting presentation they had. And this is, I think, before we finally made the decision we'd go to a single source PBM. We were still having that discussion, but we are there today, so the landscape's changed a little bit. We had some legislation that we filed last session that was going to address a portion of this, so I thought it was timely that they speak again about what they're able to do to help us bring some integrity to our PBMs and this whole prescription medicine portion of the Medicaid program. So if you'd introduce yourself for the record, feel free to proceed.
Thank you, Mr. Chairman. My name is Christopher Carlson. I'm Senior Vice President of Government Affairs and Compliance for Health Plan Data Solutions.
And I'm Gary Rutherford, pharmacist, co-founder, and Chief Clinical Officer at Health Plan Data Solutions.
Mr. Chairman, thank you very much for inviting us to speak today. Just want to start out by saying, we are in the pharmacy data analytics space exclusively, and the Commonwealth has set off on a very interesting journey with the implementation now of Senate Bill 50 and the single PBM model. Here, it's something we are not aware that any other state is doing. So we are keenly interested in the outcomes and of this structure, and want to explain to you our solution or solutions like ours that can be really a complement to ensure that first and foremost the structure that you all have implemented here is working well for the Commonwealth and for the state, and potentially it can serve as a model for other states as well. So with that, I think I'll turn it over to Gary to talk about our company here a little bit.
Okay. Well, thank you again for having us. And just as a little background, I am a pharmacist. I've had a varied practice. I've worked as a director of a hospital pharmacy. I've run a pharmacy chain, pharmacy department. I've run my own independent pharmacy. And at the conclusion of that, I wanted to basically put the brain of a pharmacist into a piece of software, and the scary thing we got was part of my brain in there, but we found it was inadequate. And so we started adding to our clinical staff, and we've developed a piece of software really that can tell you just about anything about your pharmacy spend, your drug utilization, your adherence and compliance to the regulations. Dangerous drug combinations can be identified. Coordination of benefit issues can be identified, a whole host of things. And I mean, ultimately, I can tell, in most states, you're very concerned with, is it competitive price-wise? Are we getting a good deal? And I concur with Chris that we're very impressed with what you've done in this state. My sense of it is it's the best model because you've simplified at least the contact points in managing this benefit. You've left responsibility with the managed care, which is great, because they really do or should drive drug utilization and improvement in that area. It's not just about all cost per unit. It's also correct utilization of the medications. And I do think that's an environment where that can be improved. When you look at really patient utilization of medications and correctly utilizing them, though, the most important individual is the pharmacist and engaging that patient. And, we went into this, we represent the payer. But we also really recognize and value the importance of the pharmacy provider. And we think that part of what you've done with your bill is that you've at least shown value to the pharmacy provider. But when we come in, we're very objective, and we serve the payer. And we want to give you as much information as you can possibly digest to improve your pharmacy benefit plan, both in terms of cost, patient safety, and then in your provider network and accessibility. And so our software can do just that. When in our experience, we've had experience with federal employee health plans, Medicaid plans in Ohio were the ones that did the audit that showed the spread, the $234 million in spread, and we estimated that they had overspent by $180 million in Ohio. And that's not taking it out of the pharmacist's pocket, that was taking it out of the PBM's pocket. Every client that we've had, we continue to show value. It's not always about just cost. The total cost, the price per unit on the medication. Sometimes it's a very complicated benefit. You think about that, there's over 40,000 drug entities that potentially could be utilized. You have this issue of prior authorization in pharmacy, which is a huge issue, as well as in behavioral health. You have Medicare, Medicaid, dual eligibles, and the coordination of benefits there with Medicare Part B. I think it's virtually impossible for a typical Medicaid department to really oversee their prescription benefit plan. And, unfortunately, many times we get called in after there's been a significant problem for a long period of time. And we can do something like we did for Ohio Medicaid and identify where the wastes are, and they can then attempt to fix it. But we think the best solution is to have ongoing monitoring, really ongoing auditing of the performance of the PBM and the whole prescription benefit. Then you're not chasing dollars that really are yours. And there's a high cost to that, not only in the money that has gone out of your system, but also in terms of the personnel and those that you have to hire to help you recover that. And then you get into the world of sitting in meetings for a year and a half with lawyers and arguing about which end of the deal is correct. So that can be prevented. And in our experience with some of the largest PBMs in the country, we've gotten to a point with them, once they realize that they're going to be accountable, that it truly is going to be transparent, and that they're going to have to rectify errors going forward, we actually see them overperforming. If you can believe that. It's a hard thing to believe with a PBM, but we actually see some of the big three overperforming. So we think putting in monitoring on an ongoing basis can really improve your program. Save you money? Yes, we always find money. We have a federal employee health plan that I'm just amazed. We've been with them for 7 years, and we just continually find these issues, and it's just because it's complicated. The PBM is actually overperforming on their contract. But there's always these issues. There's changes. Patients come in and out of the program. Eligibility is a concern. So, I could list a whole litany of issues that have to be monitored. We are a force multiplier. Just like special forces, we bring a whole team of clinical experts and data analytics experts and IT experts that can enable your Medicaid department to really see what's important. They can't look at it all. But you certainly don't want to go to the PBM and accept their quarterly report as your report card. It's always done from their perspective. So, thank you.
And just quickly, so our solution is a software as a service solution with the pharmacy bench pharmacist. But what it does is it takes, when a PBM submits to the payer, in this case the Department of Medicaid, it's invoice. They also submit a claims file. We re-adjudicate in the same time frame as they have today to pay the invoice. We re-adjudicate every single one of the claims that are in that file, and we then tell the payer, or provide insight and information to the payer to let them know what are the appropriate bills to pay, what on this invoice, which claims were appropriately charged and were completely fine, and which ones need to be tweaked or corrected or even just questioned. And the secret of all of this is, for us, is this is active and near real-time ongoing monitoring instead of the end of the year audit, overpay, and then trying to recoup. We find small problems, and we encourage and show the department how to fix those small problems when they're small problems. To have your pharmacy benefit manager and your pharmacy benefit itself performing well all along, instead of let's let it perform and then audit it at the end of the year. You have a brand new model. It's very promising. It's been up for 21 days with a new PBM. Very promising model. But it would be a shame to wait for a full year to see and then conduct an audit to see what could have been improved all along the way. And our solution fits neatly in the current timeframes for everyone. The pharmacies still will have the exact same experience at the pharmacy. The patients will still get their drugs. There's no delay, no time added to the process. But through the technologies now available, we can actually provide the payers the ability to say, hey, listen, I want to question my invoice. There are a couple things I have concerns with before you pay it out and have to chase it later. With that, I think we'll just pause and see if you have any questions.
You remember the old Johnny Carson routine in Karnak where he would do this number?
Yes, sir.
I see a question from Representative Sheldon.
He's reading minds again. Appreciate the presentation. Just a couple real quick questions. If you had, I think we have the commissioner online maybe here. I see deputy commissioner. So, should she have any reservation, or should she have any concern about you guys? I mean, have you talked with her? I mean, what's your play to her? I mean, how are you going to convince her that this is a good idea for her?
Well, we've actually talked.
All right.
And and she gave us a good report in terms of her experience with the Med Impact and your new PBM. And I can tell you from my experience, and I shared that with her, that their portal and their reporting is superior to most others. But here's the issue, is there's too many claims to look at, and it's their data. And so you wouldn't do an audit and ask a company to audit themselves. And so from our perspective, again, as I said, we're a force multiplier. If something has changed in its drug category, say it's changed from a brand to a specialty, or specialty to a generic, how would your staff ever catch that in a timely basis? We would know it within 2 days of the end of the billing cycle. And so we just really make you much, much more capable to catch things in a timely manner.
I appreciate that answer. One more question, maybe.
Certainly.
And just how have you decided? I know us going to a single PBM is probably made things a little bit simpler, I would think, even though it's probably, I'm sure it's the same number of claims, but coming from one person. So I can see how this model would be maybe helpful to you guys and us too, to show the rest of the country what we could do. But how do you get paid? Let's talk. How's that work?
Well, typically we're paid a per member per month basis, and we'd have to look at that with you and talk about it. Some customers do it per claim. It really, in the end, it washes out to be about the same. There are models we've used in the past that are different, but my sense is a per member per month charge is probably the most appropriate. And again, I want to say that savings ultimately are going to occur. We've never had a client that we didn't far exceed our cost. And previously when we had been here, we had talked about making it a percentage of savings. That's a tough model to administer and to implement, really. And I think it's actually counterproductive. I think you want us looking at the whole ball of wax and not just diving for the easy dollar savings. Sometimes I think it can be defocusing, actually.
Thank you very much. I appreciate that.
Senator Carroll, you have a question.
I do, Mr. Chairman, and he may have just addressed it somewhat. So as far as, is there any value at all to doing just spot checks, random checks of different batches? Do you all ever do that in an effort to cut down on cost when an agency doesn't have the financial ability to do full audits? But is there any value to that? Do you all have statistics that show how effective that might be?
We don't have statistics to support that. I would tell you that it's much more difficult. And again, one of the advantages of our system is it changes the leverage. So it used to be the PBM contracted with the manufacturers, they contracted with the pharmacy network, they contracted with the payer, and they did everything they could to keep them separated. And so nobody had any leverage. And so in this, you're actually evaluating each and every claim, each billing cycle, identifying the mistakes and holding them accountable for what needs to be corrected. And suddenly the shoe's on the other foot. You have leverage. There's lots of companies out there that'll do you a spreadsheet analysis quarterly and annually, and they'll find things for you. But it's not the same. You're not going to get the level of engagement with the PBM that we enable you to have.
And one other thing to say, in many audits and almost all audits, and certainly the audits in this space, the reason for this sampling and the just quick dive into a small sample set has been because of the cost, because it was a very manual process, right? It was pulling that information and having individuals go through it. As Gary said, we've created a software solution that runs more than 100 different algorithms against every single claim that is analyzed, and the software actually can consume all of that and then just point the clinical pharmacists to where the red flags are, where are the things that have kicked out. So it does the complete analysis, and much of it is fine, right? Much of any particular invoice is fine, and so the software can help identify, okay, where are all of the ones that are not? And that way, in any sampling, you could miss a number. You could miss most of what was a problem. And this software is what is so powerful now in 2021 to be able to allow you to re-adjudicate every single claim that has come through rather than spot checking a smaller subset.
I tell you, something that I would rather do is I'd rather make you a beta test site for a great idea, because you are the first. And for us, it's worth it for me to discount your price beyond what we give Ohio or some of the other states. Your model, I believe in. I really do. So I'd like to see it succeed.
Senator Carroll, anything else?
Thank you, gentlemen. No, sir. Thank you, Mr. Chairman.
Senator Alvarado.
Thank you, Mr. Chairman. I had a couple of independent pharmacists in my district who wanted me to ask you a specific question. And I know that when we ran this bill, this concept during the last session, a lot of the independent pharmacists were worried, saying, hey, we've got a new PBM. Let them get their feet wet. Let them kind of get established, and then let's determine things. But this is their question. And I'm not sure if you can answer it, but they said, they wanted to know if you had spoken to MedImpact about the work that you want to do in Kentucky and whether or not MedImpact had any kind of opinion about that kind of work. And I know you're kind of an auditing firm, so I'm not sure that you're able to do that, but they wanted me to pose that question for you. So I was wondering if you could answer that.
Yeah. We have not at this point spoken with MedImpact. We would be certainly willing to do so. We know that in our work across the country, we've worked with nearly every major PBM through some client, and certainly would be willing to speak with MedImpact to understand how they would perceive this. In our model, when we're doing this kind of in conjunction with the PBM and the payer, and when it's happening frequently and near real time, every billing cycle, the real benefit to everyone in the system, including the PBM, is the identification of small problems when they're still small problems, and the ability to fix those small problems before they become big problems. Big problems for the PBM, let's say there's significant overcharging. That's a big dollar amount, and it's hard to pay that back. Of course, that's problematic for the system. So we would certainly be willing to speak with MedImpact to understand, to help them understand what we do, and that we are not coming in trying to villainize them. Certainly, I mean they're brand new and on the ground, and we're hoping they can be very successful. But that we're here to help analyze the data along the way, to catch small problems when they're small, fix them before they become big.
No problem. And they had just said that they thought that the pharmacy community, at least portions of it, might feel more comfortable if they indicated that they wouldn't be inhibited by your guys' work. So it might be worth considering. But that was something they had requested. I asked today. So I appreciate you all being here and presenting your information.
Thank you.
Thank you, sir.
I think one of the biggest questions we get from independent pharmacists is they worry that we're going to slow the payment cycle to them. Doesn't affect it at all. So,
Representative Prunty, you have a question?
I think Senator Alvarado just asked it, but similarly, and I think you've already answered it. Would this add another level of bureaucracy, another layer of bureaucracy, or are you trying to minimize? I mean, how many times, who's going to keep looking behind you? And you know what I'm saying? Another level of bureaucracy. Is it adding another level of bureaucracy?
In my opinion, absolutely not. So I have a long history. Even before this company, I was actually a state procurement guy, so I'm one of those people nobody likes. But one of the hallmarks of any system is when you get an invoice, you look at the invoice, and you have somebody who's verifying, yep, this invoice looks good, let's pay it. The problem historically, this is not Kentucky's problem, this is the problem in the industry. The problem is the invoice may, in a $1.6 million Medicaid program, 1.6 million live Medicaid program, that invoice may be tens to hundreds of thousands of claims in a given cycle. Well, how is that individual supposed to really go through that and understand, is this fully ready to pay? And it's certainly no one's fault. The technology has not been there to be able to do it. Our system works within that same payment window that whatever that contract says today, whatever the contract with the MedImpact now, I guess the MedImpact now has with each of the different MCOs, right, relative to that payment cycle. And the system can sit in there and just inform that same project manager, that same contract manager who's approving that invoice, better inform them about how good is this invoice, where are the issues, and where are the things we could question. Pay what you should pay. They provide an absolutely valuable service. These drugs are being dispensed, and it needs to be paid for, and the system needs to keep moving. So the secret of our solution is this technology, along with the pharmacists, that can sit within the current structure, not create additional time, but actually just greater inform the payer, in this case, ultimately the Medicaid program, but in this case, all the MCOs, certainly on your managed care side.
When we started on this journey a few years back, we asked the Department of Medicaid to carve out prescription drugs, and immediately said, no, we're not going to do that. And I understand why. They didn't have the resources to monitor the program. But they also would acknowledge that we thought there was at least $500,000 in costs that were not accounted for. And once we got into it, I think they realized there's tremendous potential savings here. That's why we've evolved this single source PBM, which I think is a good move. And my interest in this is giving the cabinet a tool to do exactly what you folks are doing, because if you don't do it, they have to find some way to do it. And again, I don't think they have the resources to do it. Not a criticism of them. It's just they don't have the resources. Right. So this appears to be real-time online auditing of this whole process that could benefit everyone. It's just another safeguard. Right. And I still think there's tremendous potential savings in these dollars that we haven't seen yet, and I think these folks can potentially do it. I see that Deputy Commissioner Cecil's still on the line. I appreciate you hearing this presentation and would hope you would see this as an effort on our part to help the Department of Medicaid rather than hobble you folks in doing what you need to do. But you've done a commendable job so far in getting this single source PBM up and running. We know it's been a Herculean effort to do that, and we appreciate that. But the beneficiary is going to be our state and the taxpayers ultimately. And so again, just this could be one more step that helps all of us to that end goal. And I hope that you folks are receptive to this idea and would pursue it a little bit further.
Thank you, Senator Meredith. Certainly, we have listened to them. I would say that, as they noted, we're day 21 into the single PBM, and I think it is, again, very important to note what's different with this model. And you all gave it to us. You prescribed it into the statute, which is full and absolute transparency. As you know, we implemented the fee-for-service reimbursement model. So it's the lowest of logic. It's something we've been doing in fee-for-service for quite some time, and we really do feel like we've done it very well to be good stewards of the taxpayer money. And so we're constantly evaluating those drug prices and ensuring that it's being paid appropriately. And we definitely hear from providers when they think it's not. But we've got a monitoring plan. We absolutely understand the desire of the legislature to understand that we're holding the MedImpact accountable, that we can demonstrate what the cost is and the savings. And so we're going to have a robust reporting plan with this so that we can bring to you all that information and that data. Again, we should be making decisions based on data, and we plan to have a lot of data for us to be able to measure the success of this.
And I guess that's what scares me, what intimidates me a little bit, is that mountain of data that you're going to receive that you haven't received before. And I think that's going to suggest that we'll be doing that retrospectively, which is not entirely bad, but not entirely good. I really like the idea of being, real time as much as we can be with this. And I think that's one of the advantages these folks can give us to that. So I would appreciate you continue dialogue with them, and let's see if we can develop some type of relationship.
Yeah, I just want to note that this would have to be procured. Yes. So we would have to open this up for procurement.
Thank you. Appreciate your presentation today. If there's no other questions, then this committee will stand adjourned. But excuse me.
I know it's late. We want to get out of here. I don't want to leave without the deputy commissioner and Lisa Lee, the commissioner. They have done a great job implementing. And MediImpact is now, we're taking ownership of them, right? They are the white horses ridden in, and they're our state PBM. So I don't want to take anything away from those guys, but to understand how important it is to audit. You don't have to go very far, but themselves, PBMs audit providers weekly all over this state and take thousands and thousands of dollars of what they consider inappropriate money. So I don't know that we need to sit here and argue whether you need it or not. I think to hold MediImpact accountable, they probably, nobody likes to be audited. I don't like being audited, but it's part of the process, right? So I think this is something. Do we have an auditing firm that we can believe in? Maybe, maybe not. We'll do an RFP. They'll procure it, and we'll figure out what it is or not. But this does seem like a very reasonable approach to take, and for people to be concerned about it, any provider that's concerned about it. We deal with the PBM audits all day, every day. In my case, several times it seems like. So I just want you to know that I do think it's a good idea, but I do think you have to work together with Medicaid and with MediImpact, because there are people, they're good folks, and they're making Senate Bill 50 look great, and they're doing a good job, along with Deputy Deputy Commissioner Veronica and Lisa Lee. So I just want to make sure I get that on I don't want anybody to believe that we like what you're doing, but we like what we have, and hopefully you all can work together. Thank you.
Just a reminder for the committee before we adjourn that we will not be following health and welfare next month, because they'll be meeting at the state fair. We're meeting on a separate date in August. Just be prepared for that, so it won't follow health and welfare at state fair. But no other business. We will stand adjourned. Appreciate everybody's participation and time. Good meeting.
Thank you.